Green Top Guideline number 13. Chickenpox in pregnancy. Minor update 2024. This video will cover the updated points only. The new algorithm for the management of varicella-zoster contact in pregnancy is covered in the end of the video. A minor update was undertaken in 2023 to incorporate the recommendations of the UK Health Security Agency guidelines on post-exposure prophylaxis for varicella or shingles.
The first change is an introduction and background epidemiology. Previously, it stated that the disease is infectious 48 hours before the rash appears and continues to be infectious until the vesicles crust over. The update states that a more recent review suggests the transmission rarely occurs before the onset of the rash and can continue until all of the lesions have crusted over. The UK Health Security Agency advises that the infectious period in immunocompetent individuals is from 24 hours before the onset of the rash until 5 days after the rash. Immunocompromised individuals may be infectious for a longer period from 24 hours before the rash appears until all of the lesions have crusted over. Second change is in question. Can varicella be prevented in the pregnant woman at her initial antenatal visit? Previously it said that women booking for antenatal care should be asked about previous chickenpox or shingles infection only. In new guideline they state that women should be asked about previous chickenpox or shingles or varicella vaccination also. Third and major change is in question. Can varicella infection be prevented in the pregnant woman who gives a history of contact with chickenpox or shingles? Previous guidelines said that if the pregnant woman is not immune to varicella-zoster virus and she has had a significant exposure, she should be offered varicella-zoster immunoglobulin as soon as possible. The update says that she should be offered post-exposure prophylaxis. Oral antiviral therapy that is acyclovir or valacyclovir is recommended as the first choice for post-exposure prophylaxis by the UKHSA. It should be given from day 7 to 14 post-exposure. New guideline further says that when there is a contraindication or adverse effects to antivirals, then varicella-zoster immunoglobulin may be considered as post-exposure prophylaxis. Previous guidelines said that women who have had exposure to chickenpox or shingles, regardless of whether or not they have received varicella-zoster immunoglobulin, should be asked to notify their doctor or midwife early if a rash develops. Update adds that, regardless of whether or not they have received acyclovir or varicella-zoster immunoglobulin, should be asked to notify their doctor or midwife. If there is further exposure to chickenpox and seroconversion has not occurred, a second course of antiviral can be prescribed from 7 days after the exposure. Another change is that the history points of the type of varicella-zoster virus infection, the timing of the exposure and the closeness and duration of contact are properly defined. The type of varicella-zoster virus infection. Chickenpox is infectious for 24 hours before the appearance of the rash and for the duration of the illness while the skin lesions are active. Rest of paragraph is unchanged. The timing of the exposure. Significant exposure can be continuous, for example in a household or nursery. More than one exposure, for example household visitor. Single exposure to a case of chickenpox during the infectious period, or a single exposure to infectious shingles. The closeness and duration of contact. Significant contact is defined as contact in the same room for 15 minutes or more, face-to-face contact or contact in the setting of a large open ward. Previous guidelines said that the susceptibility of the woman should then be determined by eliciting a past history of chickenpox or shingles. If there is a definite past history of chickenpox, it is reasonable to assume that she is immune to varicella infection. Update says that if she has either a definite past history of chickenpox or shingles, or she has received 2 doses of the varicella vaccine, then it is reasonable to assume that she is immune to varicella infection. If the woman's immunity to chickenpox is unknown, and if there is any doubt about previous infection, vaccination, or if there is no previous history of chickenpox or shingles, serum should be tested for varicella-zoster virus IgG. Post-exposure prophylaxis should be offered if varicella-zoster virus IgG is negative or less than 100 milli-international units per ml. Of note, if the pregnant woman is immunosuppressed for a reason other than pregnancy, a history of previous infection or vaccination may not be sufficient evidence of immunity, and serum should be tested for varicella-zoster virus IgG. Post-exposure prophylaxis should be offered if IgG is negative or less than 150 milli-international units per ml. Update also says that if a pregnant woman is not immune to varicella-zoster virus and has significant exposure to chickenpox or shingles, she should be offered post-exposure prophylaxis. Oral antiviral therapy that is acyclovir or valacyclovir is recommended as the first choice for post-exposure prophylaxis by the UKHSA. It should be given from day 7 to 14 post-exposure. Acyclovir treatment is delayed until 7 days post-exposure because it was shown to be less effective in preventing clinical chickenpox infection in healthy children when treatment was started immediately after exposure. The dose of acyclovir recommended for post-exposure prophylaxis is 800 mg 4 times daily. The dose of oral valacyclovir is 1000 mg 3 times daily. Valacyclovir is a prodrug of acyclovir with better bioavailability and adverse effect profile, with less daily doses required. Acyclovir is recommended because there is more data regarding safety in pregnancy compared to valacyclovir, but if adherence to dosage regime is thought to be an issue, then valacyclovir should be considered as an alternative option. Adverse effects of acyclovir include headaches, dizziness, nausea, vomiting and diarrhea. The dose may need to be reduced if there is impaired renal function, and the drug may not be absorbed adequately when there is active inflammatory bowel disease. When there is a contraindication or adverse effects to antivirals, then varicella-zoster immunoglobulin may be considered as post-exposure prophylaxis. In this context, it should be offered if varicella-zoster virus IgG is negative or less than 100 milli-international units per ml in the immunocompetent pregnant woman, and if varicella-zoster virus IgG is negative or less than 150 milli-international units ml in the immunocompromised pregnant woman. In a subsequent Italian retrospective observational study over 20 years, a very similar number, 21 out of 50, that is 42% seronegative pregnant women that received varicella zoster immunoglobulin, developed clinical chickenpox. In contrast, 13 out of 18, that is 72% seronegative pregnant women with significant exposure developed chickenpox when they did not receive varicella zoster immunoglobulin. A recent PHE-UKHSA follow-up study of 186 seronegative pregnant women with significant exposure to chickenpox between August 2018 and December 2021 demonstrated no significant difference in the rate of chickenpox when acyclovir and varicella zoster immunoglobulin were used as post-exposure prophylaxis. There was, however, a difference in adverse effects, with 10% of women that received varicella zoster immunoglobulin reporting pain at the injection site and no reported adverse effects in the acyclovir group. The final updated point of the guideline is in question. How should the pregnant woman who develops chickenpox be cared for? It states that acyclovir and valacyclovir are not licensed for use in pregnancy but can be prescribed in the best interest of the woman on the basis of available evidence, in consultation with her. Rest of the guideline is unchanged. Appendix 1. Algorithm for the management of varicella zoster contact in pregnancy. When a pregnant woman presents with varicella zoster contact, inquire about past history of chickenpox or 2 doses of varicella vaccine. If history is positive, then no action is needed. Reassure and return to normal antenatal care. If the woman is uncertain, or has no past history of chickenpox, or she is from a tropical or subtropical country, then check blood for varicella zoster IgG from booking sample if available. If varicella zoster virus IgG is present more than 100 milli-international units per ml, then no action is needed. Reassure and return to normal antenatal care. However, if varicella zoster virus IgG is not present less than 100 milli-international units per ml, then give acyclovir from day 7 to day 14 post-exposure. If there is a contraindication to antiviral therapy, or significant adverse effects with their use, then give varicella zoster immunoglobulin if less than 10 days since contact. In case of continuous exposure, for less than 10 days since the appearance of the rash in the index case. Also, advise the woman that she is potentially infectious from 8 to 28 days after contact. And discuss postpartum varicella immunization. If the woman develops chickenpox despite post-exposure prophylaxis, or she initially presents with chickenpox, then advise her to avoid contact with potentially susceptible individuals like neonates and other pregnant women. Give symptomatic treatment, and hygiene should be advised. If the woman presents less than 24 hours of the appearance of the rash, and she is 20 or more weeks of gestation, then prescribe acyclovir. However, if the woman presents less than 24 hours of the appearance of the rash, and she is less than 20 weeks of gestation, then consider acyclovir. Avoid delivery of the baby until at least 7 days since the rash appeared. If the woman has severe chickenpox infection and is at high risk of complicated chickenpox, she should be referred to hospital. Also, intravenous acyclovir should be given. Inform women that infection at less than 28 weeks is associated with a small, approximately 1% risk of fetal varicella syndrome. Refer her to a fetal medicine specialist at 16 to 20 weeks or 5 weeks after infection. Amniocentesis to detect varicella DNA may be considered.